So this talk, I really thought a lot about this talk. It's a very short talk. It has 10 slides or something like that. And I would like kind of to summarize what has been said and where I think we stand. Now, don't throw X on me, but I will try to be objective. So these are my disclosures. They didn't change in the last 2 days, unfortunately. And you all know that CCSVI has been described in both patients with MS originally and not in healthy controls by Professor Zamboni. The main strictures have been described in the azygous vein and in the jugular veins, and that it's now very well known. So this type of problems clearly have been recently, in terms of terminology, described by Doppler sonography in this paper by our group. So, as you may read and heard during this meeting, we divided all the abnormalities in intraluminal, extraluminal, and functional. Intraluminal structural venous abnormalities present echogenic structures that extend from the endothelial lining of the vein wall with or without presence of functional abnormality, and these abnormalities include web, flap, septum, membrane, and malformed valve. Here is definition on Doppler sonography for each of those. Extraluminal structures present a restriction of the venous wall or stenosis, and we said that these abnormalities include stenosis and annulus. And here are the definitions of this. Functional venous abnormalities represent abnormal cerebral venous outflow in the presence of structural venous anomalies. And I think that to some extent we will need to revise that. These abnormalities may include reflux, bidirectional flow, paradox, and no flow. And they are defined here. As you may hear, paradox may be what we call paradox. Dr. Siddiqui may call pulsatility on IVUS. So clearly at some point we will need to adjust these terminologies. I already showed this slide a number of times and I'm going to go fast through it, but just so you understand, so here we see these abnormalities in the jugular and azygous veins. We define them on Doppler, we begin to define them on IVUS and on catheter venography. Clearly, these extraluminal abnormalities are more morphological and related to the wall, and I would say that we think that annulus is an extraluminal abnormality and not an intraluminal. I might be wrong. And then we know that these functional abnormalities in terms of reflux, no flow, or paradox are present in those veins. And finally, we know that people with may have collaterals, even healthy controls. Now, so I showed you a couple of things, and now the question is which comes first? Do the intraluminal abnormalities come first? Do they create functional abnormalities? Do the functional abnormalities lead to collaterals? And does the stenosis of the vein happens when there is no compensation anymore? It's a quite nice hypothesis. The only problem is that here comes Dr. Hu and Dr. Chung, and they clearly say you can have a jugular vein reflux, and they don't say nothing about structural abnormalities. Do they see in those people intraluminal abnormalities, extraluminal? We don't know. So if you have a heart disease, and I showed you the data on our risk factors, does the heart disease clearly without the presence of structural and extraluminal abnormalities in those veins, is able to produce a reflux, which means does this reflux comes from actually not even jugular or a zygous vein, but from the other parts of the body. That's a possibility, certainly. So the timelines in finding out which comes first is extremely important, in my opinion, in order to understand. And that's why we should begin to do some studies on longitudinal basis very early on and begin to follow these subjects to understand, okay, you didn't have a septum, but now, after 15 years, you have a septum. Or you didn't have a membrane or a stenosed vein, and now you have it. I don't know the way how we are going to answer to this question, if not with this type of approach. Now, going further in terminology. So how can we classify these venous anomalies? They can be morphological, as I told you, of structural nature, intraluminal or extraluminal, and I think that I covered this pretty well. They can be functional, reflux, bidirectional flow, paradox, no flow, and I have to say that coming to this meeting, I had no good opinion about the flow anomalies and the degree of flow anomalies, but I think that clearly evidence is increasing that we will maybe be able to say, hey, you have so much percentage of flow altered, or maybe these cutoffs that have to be validated, say 6 to 8 milliliters per second or things like that. So clearly in a more quantitative way, we are going to be able to define what is a functional abnormality. And then we have composites. So what CCSVI was presented with is a composite. 2 venous hemodynamic criteria established by Professor Zamboni, giving an answer yes, no. But VHSS, which is a severity score and goes from 0 to 16 and takes into account all abnormalities that fall into this category, in all our association studies were better correlates of MRI, disability, and everything we looked at than the CCSVI. So I would disagree with Robert Fox when he said you should not do the association studies until you establish the criteria, because criteria can be established in different ways, which will follow on my slide, and one of these ways is to look for association and clinical or other parameter validity. Who knows whether 2 years from now at ISNVD meeting we will not have a composite Z-score which will take information from Doppler sonography, MRV, catheter venography and IVUS, and will be much better predictor of venous anomalies with impact or no impact for clinical consequences than our criteria we are using at the moment. Now, hypotheses get established. That's what Professor Zamboni did. He established a hypothesis. He tested the hypothesis, and he established the criteria, but fundamental problem, and I don't know if Professor Zamboni is in the audience. Yeah, he is. But one of the fundamental problems is that there have to be 2 data sets, one for testing and one for validation. And so what we are doing now and what we should do in the future is trying to gather all this information, establish the hypothesis if for instance, if this score is better, we believe it's better than its two criteria or VHSS, then we should, test it first this, and then take a validation data set, which will be completely different data set, and understand how it works. So sensitivity and specificity, in my opinion, has to be established versus other groups, where there is healthy controls, ONDs, whatever you want, versus the gold standards, which we believed is catheter venography, but turned out not to be so great gold standard, and do the association studies. Because I honestly believe much more in venous hemodynamic insufficiency severity score from 0 to 16 than I believe in CCSVI yes/no. Then, and only then, consensuses are achieved and standards are established. And we are far away from that, and we need to take the right pathway. We are here now and beginning to do some of these works, but we are not here. And we can jump in the future without doing the necessary work. Along the pathway, we need to understand origin of these venous anomalies. This is a paper that I looked this morning by Dr. Lee, and there is another paper also, in which he's claiming that these are truncular embryonic malformations. But if you read these papers, they don't have a real evidence to say that these are truncular embryonic malformations. Based on what? Based on belief. So I have other beliefs, and Chung and Hu and many of you who presented this week, that they could be aging related. We never spoke this week about immobility versus exercise. Who knows whether those people who, exercise more don't have less venous abnormalities. And if you think all these neurologic diseases, you are less mobile. Your blood does not pump throughout the body as you do when you do exercise. And clearly inflammation, and clearly viruses, and clearly, all flow abnormalities at periphery and in the central nervous system. So who is affected by CCSVI? We know that jugular vein reflux is present in a number of diseases, as we heard this week, more in those who are older than 55, especially those who are older than 75. They even have evidence of leukorrhyosis and white matter lesions in the brain. I think Buffalo City EVD study with 300 healthy controls is going to be very important into understanding effect of outflow problems on aging. Pediatric study that we are doing is also important, because if we follow these people longitudinally, I think we will understand a little bit better. For now, based on this meeting and what's around, I think that we can say that MS is affected by CCSVI, Parkinson's disease, migraine. These are all published studies for MS and migraine. I told you and couldn't share with you more, but I can tell you that many neuromuscular, autoimmune, neurodegenerative, and vascular diseases are probably affected. Now, what's in the third column? Other systems. I think that bowel is definitely affected. We don't have evidence, but we are going to investigate. Even at this meeting, there were presented different states connected to renal and iliac occlusions. I went, not in some journal, but on the Wikipedia this morning, and took two mostly common definitions for disease and syndrome. A disease is an abnormal condition affecting the body of an organism. It is often construed to be a medical condition associated with specific symptoms and signs. A syndrome is a group of symptoms that consistently occur together, or a condition characterized by a set of associated symptoms. So is a CCSVI a disease or it's a syndrome? Now, you need to consider that body parts that have been until affected by the CCSVI are jugular veins, azygous veins, renal veins, iliac veins, maybe others. That symptoms that are improving after treatment are headache, fatigue, brain fog, autonomic control, temperature, bladder, bowel, sleep disturbance, balance, and maybe cognition. So there are symptoms. There is a certain organism part, body part. So I think maybe according to the definition from Wikipedia may qualify for a disease. And that brings me, and I hope that Professor Zamboni will not be angry with me, with a question: is term chronic cerebrospinal venous insufficiency adequate to reflect all what was discovered in the last 2 years? And this is going, in my opinion, to be an issue for the future, because just with the CCSVI, we are not going to be able to describe everything what we are finding. And that's something for thought. Safety has to be established in mid and long-term studies, and we discussed that. Efficacy has to be tested in blinded placebo-controlled phase 1 and 2, and then better designed phase 3 studies. Efficacy outcomes, as I mentioned a number of times, have to be disease-modifying, look on quality of life, symptom, and management. But then there is a huge point. So we spent 2.5 years to talk about how we need to do these studies, and we are improving. But then if you put the next bullet point, and so what about outcomes in other neurologic and non-neurologic diseases? Because if you have CCSVI in Parkinson, even more severe than in MS, are you going to measure the lesions and brain atrophy and EDSS and relapses? No, because for each and every of these diseases, we will begin to look clinical outcomes. And then it's question whether, if so many conditions are affected, we are going to follow the outcomes for every disease, or, as I said this morning, this is something that we believe may improve if you reopen the veins independently of the SDMT test or fatigue or that. And so we will begin to design our questionnaires and tests and outcomes not based on the disease we are trying to help with, but based on a fundamental disease we are treating, and that is the CCSVI. And clearly, I already alluded that value of open-label studies is limited. I think we heard that, but we can learn from them, and for now, only they can be done if research approved, in my opinion. And clearly, in all this, risk versus benefit and probably versus cost will need to be established. I presented this slide, and I'm not going to go much in this anymore. Does CCSVI exist? I think it does. It's not common only for MS and unique, but for healthy subjects and other conditions. What represents? I think that evidence is increasing that can be rather a disease than a syndrome. What is the most sensitive test? We first need to, define the terminology of what we are looking for, and then begin to look for gold standards. Association studies, in my opinion, must be continued, because we will learn from them what works the best. And treatments, I think, should be promoted in safety, research, and ethical fashion. So I will finish with my two kids who really I'm not devoting enough time, so this lecture is for them. Thank you.
Thank you very much. Fantastic speech. Any questions, comments?
I think we can pass this. Thank you.
Let me introduce Dr. Adnan Siddiqui, who will talk about design of randomized placebo-controlled endovascular trials in MS.
Thank you. Can you hear me okay? Yes. So, my disclosures. I'll talk about the trial that we conducted at Buffalo, and really was a multidisciplinary collaboration. I think that's the first thing to keep in mind as you start thinking about trials, is that this is not the domain of one field. This is the domain of many fields. In fact, I was really educated by Professor Zamboni when he told me that from his assessment standpoint, he thinks that just having a blinded neurologist is not good enough. You really need to start involving physical therapists and occupational therapists and really blinded people who can independently evaluate specific aspects of outcomes. So I really feel this is important to consider. The principal investigators include myself, Professor Zavadinov, Bianca Weinstock-Gutman, who was here earlier, and my partners in the neurosurgery department. So the problem with MS from a trial standpoint, interventional trial standpoint, is that compared to other endovascular diseases such as brain aneurysms, carotid artery disease, stroke, etc., this is a chronic progressive disease. And so evaluating efficacy is not as straightforward as for other neurovascular conditions. Additionally, the most common type, the relapsing type, really becomes very hard to evaluate because it has a rather staccato type of presentation rather than a progressive course. And within this heterogeneity, there's tremendous variability between patients, their symptoms, their complaints, and benign forms of MS comprise a significant part. So the question also becomes, well, these patients likely will do well without us interfering in the natural history of the disease. So we really need to have larger studies rather than smaller studies to address the variability which normally resides within multiple sclerosis patients. Disability, we know, is cumulative, so we should not expect a major neurological deficit to improve significantly after any one intervention. And that really needs to be kept in mind as well when we design these trials. The most important thing when considering endovascular intervention is to consider safety. Vascular diseases such as brain aneurysms and stroke have such tremendous rapid onset catastrophic morbidity or mortality associated that intervention, one, is easier to justify. Second, easier to prove efficacy because, you have a column of 80% mortality in rapid succession. If you bring that number down to 50% mortality, you have a cure. That's not that easy. With MS, it's really primarily an issue of quality of life, and that becomes a harder thing for us to prove. So the first thing for any trial really has to focus on safety, safety, and safety. That's the most important thing, and I'm sure as far as our neurologists, our trialists are concerned, this is not something we have proven effectively to them as yet. Second thing we have to deal with is asymptomatic disease. It's well established that ongoing lesions can occur even in patients who are clinically asymptomatic. So how does one address that in the realms of a trial where you're trying to compare? So you really need markers, surrogate markers to just the clinical conditions such as MRI, etc., to really address these issues where the staccato clinical presentation may be less reliable than maybe an MR-based activity of disease. So asymptomatic activity, we really need to have sensitive means for detection, and really this is where MR becomes very, very valuable in addition to clinical parameters, whether it's the functional composite or the EDSS score. The other thing is disease activity. At the beginning of MS, when it's clinically isolated, it may take a much longer time for it to be detected. And somebody else, I think, the folks from Albany have shown that if you really treated these patients within 5 years of their symptom onset, you were much more effective than when you were 10 years plus from symptom onset. So this is, again, a challenge for us as the patients. What kind of patients are we enrolling? So it's important to be consistent in terms of the cohort that you're going to look at. So if you put in a whole bunch of 2 years within diagnosis and a whole bunch of 15 years within diagnosis together, you may get jumbled data that may be hard to interpret. Outcome measures, disease activity, whether it's relapse rate, time to first attack, attack-free time, I think these need to be matched with consistent, regular interval MRI scans, whether it's new T2 lesions, GAD-positive lesions, etc. In addition, we need to look at disease severity. Disease severity is more of a cumulative measure where you look at EDSS and the functional composite score, as well as possibly looking at whole brain volume, total T2 lesion burden, and brain atrophy, etc. And it's interesting to look at maybe some of these blood flow parameters that have been presented may be very useful in this regard as well. Inclusion criteria. Should we include patients who are already on therapy? Is that a prerequisite? If you don't, well, are you looking at people who are not symptomatic enough? Or on the other hand, if you have patients who are on Tysabri, given at least those who can take Tysabri, that has a tremendous impact on the clinical course of the disease. And so it becomes really hard to interpret data where you have a heterogeneous population on multiple different therapies. So it's really important to give consideration to these kinds of issues when you're designing the trial. Including of all patients or only patients who fulfill Doppler criteria. That's another one. I would surmise that it's important that when you are basing intervention on the premise that there is CCSVI and there's venous stenosis, it would make sense to first identify benefit in the patients who are most likely to be affected by it. Counterpoint to the Albany presentation, where they found abnormalities much more commonly on cathetervenography than in Doppler. But then that really opens a Pandora's box as to what is CCSVI, how do we detect it, and how is it causally related. So it's important to sort of pay attention to these Doppler criteria. Again, in our experience, Asymptomatic seems to be much more effective. Similarly, Professor Zamboni's original data cohort also suggested that. And so, well, how do we evaluate Asymptomatic? We don't really have any good ways. I know Mark thinks that MR would be the way to go, but it's still preliminary. So it really becomes important. What about secondary progressives? Disease activity is reduced, but outcome may be more difficult to measure. And then in terms of cognitive follow-up tools, how do we really assess it? Are there surrogate markers such as the retinal nerve fiber layer thickness by OCT? That might be an interesting marker to utilize alongside all the other markers that we're looking at. So for our trial, what we really were thinking is, how do we randomize these patients? On what basis do we randomize them? And so we had no parameters to understand what we were looking at when we first designed this trial. And so we based it on arterial disease. We based it on that long-held 50% stenosis. Now, you heard over the course of the last few days that we don't really know what 50% stenosis means when it comes to a vein. We don't understand venous hemodynamics, but that's certainly what we started off with, and that may need to be revised down the road. And then, how do you define that? What modality constitutes that 50% stenosis? These are all issues that we have to contend with, and we may be wrong, but you need to come up with one definition and then stick to it for the course of your trial. How do you blind? That's another interesting dilemma that we dealt with when we did our open label phase, because every time you'd blow up a balloon in somebody's jugular, they would feel it, and they would scream bloody murder. So how do you deal with the pain that's associated? And so I think it's really important to have distractions. Sedation is one way. Loud, conflicting music, whether it's heavy metal, certainly not Bach or Brahms, but something really rather robust, is useful in that regard to confuse the patients. And we manually elicit noxious stimulus in conjunction with angioplasty, and that creates another sort of painful noxious stimulus which is universal even when patients are undergoing the sham procedure. The blinding of neurologists, I mentioned earlier, and Paolo mentioned blinding of other evaluators, whether it's the rehab doctors or occupational physical therapists. I think that's really the way to think about it. And how do we follow up? So briefly, just quickly going over our premise trial, I mentioned it earlier, collaboration is key, and we really wanted to see first safety, and second, get some evidence if there's any pilot evidence that there is some effectiveness. So that's how we thought about it. Prospective randomized endovascular therapy in MS. First, we got IRB approval to be able to do this. Second, it was multidisciplinary. That helped the IRB approve this trial. So if it was just me going up to the IRB, I think the IRB would have a harder time approving this than if I went along with the neurologist and the neuroradiologist, all of us going together to say we want to do this. Makes a whole lot more sense, becomes easier for the IRB to approve. Third, how do you fund it? I mean, you cannot get reimbursed for sham procedures. In case you have not realized that, that's the biggest limiting factor here. And the evaluations that you're performing on these patients, because we all want to get all the data we possibly can. We want to do the MRVs and the perfusion studies and the Dopplers and the IVUSes. This is an expensive study to conduct. And in our experience, at least in the United States, giving $0 to the interventionalist, $0 to the neurologist, $0 to the radiologist. Just purely equipment and hospital cost was about $25,000 per patient for the entirety of the study. So it adds up. So you really need to partner. We partnered with our hospital, told them this was an important disease in our neck of the woods, which is upstate New York. We partnered with our endovascular partners. We got money from Volcano. We told them that IVUS would be a good tool. We had no evidence of that, and it looks like we probably have been partly right about it. But that IVUS would be a good tool to look at these lesions, and so we partnered with Volcano, we partnered with EV3, which provides balloons, etc., for interventional surgery. And those are the ways you get money, because you're not going to get it from the NIH at this point, till we have some of these preliminary data. And then we can potentially go. But more importantly, there was no physician reimbursement, there was no patient reimbursement. So patients were not given money to do this. And there were certainly no professional fees associated with this entire trial. This is a long thing, but I'll briefly summarize this. Number one, we wanted to see safety. Number two, we wanted to see the morphology of these lesions based on catheterovenography, intravascular Doppler. We wanted to look at them on MRV. We wanted to look at them with CTV. Then we wanted to see the effectiveness looking at clinical outcomes, both EDSS and functional composite, but also functional improvement from the vascular standpoint by looking at the Dopplers and MRVs, etc. We want to look at multiple quality of life measures, multiple cognitive measures, as well as retinal fiber, nerve fiber layer thickness by OCT. So we used all of the parameters, everything that we could think of. The first thing, though, the primary endpoint for any first step has to be safety. You have to show that it's safe. That's our primary endpoint. We have met that primary endpoint for the phase 1. We are one patient away from the secondary endpoint. And secondary endpoints can include, well, how effective was the therapy structurally? Were you able to open the vein up? And did you make the patients better? And were you able to change the course of predicted natural history based on MR? And then tertiary endpoints include quality of life measures and other investigational things such as CT perfusion, etc., that I'll not go through. And this continues on because we thought this is our one shot. We better test whatever we possibly can to really show some effectiveness, because we'd hate to show that we were not able to change the number of MR lesions, but really significantly impact quality of life, etc. So it's really important to be all-inclusive rather than restrictive when you're thinking of it. So our phase 1 is done, phase 2, 1 patient away from being done. And really in the end, it's a multi-modality, multidisciplinary approach that will really allow us to get pilot data to be able to do the kinds of real critical phase 3 trials that Robert was talking about. And I'll end there. Thank you very much.
Any questions? Too much data. So now let me introduce. It's too much life. Dr. Hubbard will present national push to gather prospective data on MS outcomes.
Don Ponick had a family illness, so he was not able to come to the conference. So I'm going to present this. So this is basically some summary of the Hubbard Foundation Multi-Center CCSVI registry. It was funded by my family foundation, but also each IR was required to pay a small amount. It started at $200 per patient. And now it's actually $350. I mention that because when we talk about registries, everyone says they're incredibly expensive. SIR estimated a couple of $1 million. We talked about it in this society. We also thought it might be a couple of million. It can be done. We have 26 sites nationally. We've treated about 400 people. We collect data at baseline 1 and 6 months. So this is how it flows. We get the informed consent on day 1, MR safety questionnaire, demographic questionnaire. The MSIS is one of the validated MS measures. It's a self-report measure. So in general, the EDSS requires a neurological exam. The MSIS does not. On day 2, they receive the venoplasty. A couple of days later, they have a conversation with the clinic to make sure everything's going okay, and then they get the MSIS again at 1 month and 6 months. It's taken the first time at our facility, the MR facility, and then the second time and third time it's taken online. So we had 66% were women. The mean age was 47, range 20 to 74. 42% were relapsing remitting, 14% primary progressive, 26% secondary progressive, 35% were on disability. Average duration to first symptoms, 16 years. Duration since diagnosis, 11. It's the only disease I'm aware of where we have to report when the diagnosis is made and when the symptom first came up. Kind of an interesting problem there. Only a small amount of these patients were on medications, and only a few medications. So 75% were on no disease-modifying drugs. In fact, most of these patients were no longer seeing neurologists. We looked at MRV flow, particularly in the internal jugular veins. The mean flow on the right side was 6.2 milliliters per second, left side 4.3 milliliters per second. And then we also looked at flow, which we defined as percentage of the cardiac cycle. And then we defined by flow that was going both ways as circulatory flow, and that was 36% in the right and 40% in the left. We treated the usual sites. 30% were left jugular, 89% the lower, 30% in the upper left jugular, 89%, the lower left jugular, 69, 26%, the right upper, 81, right lower, azygos 63%, 9% lower, and in the common iliac, 2% of the patients. So these are the results of the MSIS at 1 month and 6 months. So the p-values are the p-value for 1 month compared to baseline, and for 6 months compared to baseline for the physical and the psychological scores. And so as you can see, all of those were significant, both at 1 month and 6 months for all of those measures. What it actually came to look like is like this. This is the MS physical scores at 1 month. There's a research paper out that compared the MSIS to the EDSS, and basically that paper concluded that a significant EDSS score correlated with a change of 8 in the MSIS. As far as we can see, there's only one paper that has actually looked at that issue, but because of that paper, we broke it out into groups of 8. And so as you can see, for the change, so a change from 0 to 8 and then from 8 to 16, those are the first two categories. And so this is the 1 month physical, 1 month psychological, 6 months physical, and 6 months psychological. So it kind of fits in with what the sort of word is out there. You know, there's only been 2 other clinical outcome studies. Zamboni's first study of, what was it, 78 patients, I think, and then the Ladiga study of 93. There's one other study of 4 patients, but as far as I can find, those were the only 2 clinical outcomes studies. It was the results were significant at 0.01 level, and in general, about 60 to 75% of the patients get better. Pretty much no one gets worse, but a lot of people have no change. Registry data is, of course, not placebo-controlled, not randomized, not double-blinded. I believe there's still a role to collect this kind of data, but obviously we can't prove anything with registry-type data. It does provide safety data, provides pilot clinical outcome data. It also provides the experience to aid in the design of a clinical trial. I myself am nervous about doing a placebo-controlled trial yet. Are we really ready to do that? I think it's fantastic that Buffalo has the guts to go ahead and do that. A pretty darn expensive trial, but I think we need to collect that data. And it can be done relatively inexpensively. You know, we really only have data on some 1,000 patients altogether, and yet we hear that 15,000 people or more have had this treatment. I don't really get why every IR that's doing this isn't participating some mechanism to collect their data, especially when it's just not that hard to get registry data. It doesn't have to be that expensive. I think that's an important early goal for this. Thank you very much.
Quick question, Dave.
I'm not taking any questions from you. No way. It's too dangerous.
I just wanted to know how you established, who needs to be treated.
You just treated everybody. Did you have some criteria for establishing you are going to get the treatment, you are not, in day 1?
These patients were coming to get treated. We did MR venography before they were treated, but they were coming to be treated. So we basically tagged on MRV, and in my case, fMRI bold, to this group of people that we knew were coming, and we were going to do so we did it the day before and the day after. And we're submitting that data in another paper.
Just to reiterate the point you're making, it's absolutely critical, especially when the field is as nascent as it is, to have parallel ongoing registries as well as placebo-controlled trials. New advances will come through registries. Safety data will come through registries. New techniques, effective techniques will come through registries. And then once we have them, that's when you go on to placebo-controlled. Unfortunately, in this particular disease, we had to put the cart before the horse because there's just so much resistance to the idea that randomized was required up front as well. But I commend you. I think it's absolutely right. All data really needs to go into registries so we can glean what works, what doesn't work. This is really very encouraging data to see that you're seeing the improvement that you are seeing.
Thanks.
Any other comments? If no, so let me introduce next speaker will be Jack Burks. Huh? Okay, so. Okay, so Paolo Zamboni will talk about brain dreams.
No, sorry.
I yield the floor. No. I think there will be a nice summary by Paolo.
Sorry, Jay.
I can't wait to hear your talk, so I'm going to be quick. I have nothing to declare. I've talked to you before. I want to just make some remarks while this is up there as to where neurologists stand. You know, the questions that we have is, does it exist? Well, I think there's an overwhelmingly interesting group of papers that have been presented this week and before that really make this an important topic for us to consider. At the same time, as I sit in the audience, I'm struck by the number of questions that we still have. How do you make the diagnosis? How do you know it exists, and what form it exists, and how bad it is, et cetera? And it's really nice to see the efforts that are being put forth to better define the diagnosis of CCSVI. And the second question is, what is CCSVI procedures? What do they do? That seems like a straightforward question. Is it a disease-modifying therapy? Is that what we think it does? Or is it asymptomatic, or just make people feel better? Well, that has value too, but we still have to figure out how to define that. Because neurologists would say the answer is it's a placebo. So we don't have to answer any of these questions, because this really doesn't have any effect other than placebo. And I think what we're seeing is more and more data and more research that's aimed at showing the value, if any, of this. But we must realize that there's probably over 20,000 procedures, although we don't know how many people have had this. That's the sad part. We don't have the safety data. We don't have the efficacy data. As Dr. Hubbard said, 150 patients maybe out of 20,000 we have data. So from the neurologist's perspective, that's very disconcerting. From the patient's perspective, that's not too disconcerting. Data for neurologists. They're not for patients. We want to get better. We're willing to take the risk. We're willing to pay $20,000 because we are convinced that it works. Well, put yourself in the neurologist's position when they're confronted with this in their office. And the response to many neurologists, I think, is that they're frustrated, they're confused, and they're basically saying, we're not going to be believers in CCSVI until the people who are doing it have shown it's a scientific basis. And frankly, we don't know what to think. So what do? We duck. We avoid. We try not to talk about it with the patients. And at the same time, there's a lot of resentment, I think, harbored by neurologists that they believe that the endovascular world has been promoting CCSVI, sometimes covertly and sometimes overtly. Just go into Google CCSVI and look at the advertisements. That's what the neurologists are faced with. So they're faced with angry patients with very poor data, although interesting data that they don't even know about, because at the neurology meetings, we don't hear this data. Dr. Zvadnov tried to present from the floor some data. Oh, well, they just dismissed that. I was so embarrassed. That we're not more open to this. So let's go back in history. What happened? What went wrong scientifically? Dr. Zamboni did a pilot study. He did a pilot study that is not dissimilar from all the other pilot studies we've done. We want to get some questions that we can ask in future studies and ways to ask those questions. That's a very appropriate way of doing it. So what happened there? Why is all the fuss? This is a pilot study. And Dr. Zamboni in his paper says, this does not prove anything. It just stimulates more research. Every speaker here has talked about research. It says, we need more research. Nobody that I've heard has stood up and says, this is the cure for MS. This is the whatever for MS. This is what we need to be pushing on. Nobody said that. But if you ask neurologists, They say, yeah, that's what they're saying publicly, but privately, you know, they're recruiting patients. I think that there's a lot of misunderstanding and a lot of confusion, and I'm going to talk about how to deal with that. So what happened? So how did it get to this situation? Well, I think that that we have to take some responsibility, but the press really pushed this. A pilot study they pushed worldwide as liberating people from multiple sclerosis, and a neurologist who doesn't send all their patients to get this done is not being a good doctor. They're being criticized. I can tell you that doesn't feel good as a doctor to have the press tell me I'm doing something wrong. And basically, so we're saying, okay, before we jump on the rock star bandwagon here, give us a little bit of data, okay? And that's what everybody in this room has said. That's what everybody this week has said. So we're all in the same agreement. So the issue here is not, should we do more science? The issue is, how should we do more science? And how should we be more collaborative when they do this, science? And but my colleagues, who I love dearly, are basically saying, we want scientific data. What does that mean? I think part of it means we want to keep ducking until this thing goes away like snake venom and bee stings and stuff like that, and we don't have to deal with it. But the time has passed for that. Now we must address the issues. Thank you. And we're ready. Just, you know, there were a number of neurologists here. Dr. Coyle, I thought, gave an excellent presentation about outcomes. I'll bet it blew you away. If you listen to her, how complex it is to do outcomes. Relapse rate goes down? Not necessarily. It does, but it may not mean anything because placebo does that. EDSS, yeah, the gold standard. No, we have problems with EDSS. It goes on and on and on. Neurologists who've done clinical trials understand that. But it's really hard to understand why relapse rate goes down naturally, and why their EDSS. Why do over 50% of patients get better on their EDSS when they're treated with placebo at 7 years? So how old is the placebo for? I don't know. But these are really complex issues, and the only way we're going to solve them is doing it together. And I have to applaud the people from Buffalo and the people who spoke today who have really been trying very hard to keep their eye on the ball. Not be distracted from all this flack that goes around, because, you know, people are being ostracized. I mean, I'm being ostracized, and I don't even speak for it, you know. I can imagine what the people who actually have a center where this is done to do. It's a very difficult situation. So, what can we do? We have to start collaborating. And, well, we can ask the questions. Do we really need neurologists? Well, unfortunately for the endovascular world, I think you probably do. Because you're going to have a hard time. And we've got some neurologists like Dr. Zvadnov, Dr. Weinstein-Gutman, who are really working hard to do the right study. The study you just saw presented from Buffalo is such a great study that, as a way to start with this, Dr. Hubbard's idea of a registry, duh, 20,000 patients and no data? I think we need a registry. I don't think anybody's going to disagree with that. So the question is how, not whether we need it, but how. And so I'm going to suggest that we get together we form a group of the leaders in neurology and diagnostic, interventional radiology and endovascular surgery, trial design experts who can really help us design the right trials, get the immunologists and the iron metabolism people and people who are experts in vascular anomalies, get other healthcare professionals, get everybody who's interested. And also, I would suggest we include MS patient groups. You know, the CCSVI Alliance has been here all week. I think they have a say in this, they have a stake in this, and they're going to help promote whatever this group decides. And also the MS advocacy organizations. It's nice that the National MS Society and the Canadian MS Society have funded research, but we need to get them more involved in helping us plan for the future. Okay, so here's the format I'm going to recommend. And the reason I recommend this format is that I've had some experience with it a few times, and The first time was around 1985 when the consortium of MS centers was saying, what do we do? Does rehabilitation make a difference? How do we do trials? We had no treatments for MS at the time. And we had a meeting in Denver at the MS Center where I was the head of. And we said, what do we really know about MS and MS research? And what do we do when we believe this works, but we don't really know whether things work? And then how can we set up a process to design and implement research protocols? And it's amazing. You sit around the room with people you don't even know. You have dinner with them, you get to know them, they're real people. They're not some monster neurologist, you know. They're actually, most of us we're nerds. Okay, but we're pretty nice people too. And we get to know each other and say, okay, now how can we answer the questions? So let me give you 6 questions. First, what data do we agree that is known about CCSVI? It has solid scientific basis. We can list it. This is what we know. And then, what do we think we know? Or what do we believe to be true? But there's no scientific evidence. So we actually list that. And then we list what do we don't know. We all agree that these are the things that we don't know. And we try to get a consensus. And what that does is that builds camaraderie. Because the things that have been said here is the same things I hear in the neurological meeting. It's just a different spin to it. So I think we have a lot in common. And then we say, what do we need to do to fill the gaps? We prioritize the gaps. What's the most important thing we need to address? What's the second? These are the things that we really need to address. And then what are the roles of each of those people in this room, the collaborative efforts? Will you do this part of a study? Will you do this? Will we put together the 3 of you to do this? It's amazing how well that has worked in the past. And then, obviously, how can the research be funded? These are big issues. And I can tell you, if we can get a conference like this funded by the NIH, and the NIH does this, under their auspices and their format, and we come out with some sort of a paper, whether you want to call it a white paper, a consensus paper, or whatever, this is what needs to be done. And you take that document to the funding agencies, you're going to have a lot more clout than an individual intravascular surgeon or neurologist or whatever to get research done, at least in the United States. And I think that we really have an opportunity, because I do think there is enough preliminary data to say now we need to put real meat to the science, and we're seeing some of that meat already being formed by the papers that have been presented here today. And so I'll end by just saying that we all agree on what needs to be done. A meeting of the minds can tell us how to get it done. And that way we can satisfy the neurologist, the endovascular people, and the patients. Thank you very much. Oh, is there questions? Question?
Any questions?
Any questions? Thank you.
Thank you very much. I'm speaking about a trial called Brave Dreams, brain venous drainage exploited against multiple sclerosis. And the good news is that last week the regional government in Italy decided to fund completely with 3 million euro this trial. Is a randomized multi-center study for evaluating the efficacy and the safety of angioplastic surgery of the extracranial veins in the treatment of MS. The design of the study is a multi-center, randomized, blinded, with same controlled parallel group study. The duration randomization will be 6 months. Follow-up for each patient, 12 months, with a reevaluation at 15 months. Setting Italian MS center accredited by the National Health System. Coordination and promotion is my university. This is the study flow diagram. We have verification of inclusion and exclusion criteria in relapsing, remitting, and secondary progressive patient. The association with this CCSVI will be performed by Doppler, and patient negative will be excluded. Therefore, there will be functional test and baseline magnetic resonance, randomization to venography and angioplasty on the treated arm, and control group only venography, follow-up, and results evaluation. Inclusion criteria will include patients from 18 to 65 years old. MS is defined according to McDonald's criteria, including both relapsing, remitting, or secondary progressive course, with a disease duration of 10 years, not more, and an interval of EDSS between 2 and 5.5. Confirmed diagnosis of CCSVI by means of Doppler, and we include 685 patients. Primary endpoints are clinical in a concise functional endpoint, and magnetic resonance imaging, T2 lesion volume and number. Primary clinical endpoint is 5 tests measuring by instruments with more 5 functional indicators of neurological symptoms in MS. It will be walking, there is the ratio step length, step rate, walk ratio, WR. This was chosen to substitute the 25-foot, 6 minutes walking and other metrics, because the latter are more affected by placebo, eventual placebo effect, because someone tried to get the better performance. But from a neurological point of view, the ratio between step length and step rate is very difficult to be affected, more difficult to be affected. Balance, it will be evaluated in static condition as a capacity to keep the balance swinging in different directions using the same instrument for all the existing center. Manual dexterity will be evaluated by box and block test. Sphincter control, this is very interesting because we use ultrasound measurement of post-void residual capacity of a bladder, and visual activity read in low contrast optotypes on lines of fonts, progressive is smaller. This is a validated test also. On the basis of a threshold normal pathologic value and a clinical significant difference upon follow-up, the function would be classified improved, stable, worsened. The integrated evaluation of the 5 functions will allow for the classification of the patients in improved, stable, worsened, or fluctuating. For example, if you should have balanced improvement and bladder function worsening, you are fluctuating. Primary MRI endpoint, this was proposed on the basis of a pilot study we performed together. Robert Zivadin of a Buffalo group is the assessment of new T2 lesion or variation in T2 lesion volume compared to baseline. There is a list of secondary endpoints. These are very important. Another very important observation is that the clinical endpoints will be not assessed by the neurologist responsible of a single center, but by physiatrists using validated scale for evaluating of a disability. Annual rate of relapse, variation in disability measured by EDSS, proportion of patients with disease relapses measured by a categorical endpoint, percentage of patients with restenosis in the treated arm of the studies at 12 months, disease activity by means of T1 gut pulse lesion, fatigue measured with the validated questionnaire, emotional states, anxiety and depression, because they may affect cognitive function and other, as we learned today by Ralph Benedict, general and cognitive states, MoCA, memory, careful calculation with PASAT, impact of bladder incontinence with questionnaire, and of course the advanced event correlated with the treatment under evaluation. So selective venography and percutaneous transluminous angioplasty versus selective venography and sham percutaneous transluminal angioplasty. Examinated pathway, lumbar veins with left approach, left renal vein, azygos vein, and the internal jugular veins. Randomization will be carried out on the same days as an intervention by the surgeon or the interventional radiologist responsible of angioplasty, true or simulated. This is the only individual who is aware of the randomization, and usually the operation will be done in a different hospital, respect the hospital of neurological center, of the MS neurological center. Patients, neurologists, assessors, neuroradiologists, and statistician will be blinded to arm allocation. Follow-up is scheduled to last 12 months, and patients will be examined at programmed interval 0, 3, 6, 9, and 12 months, including clinical examination, functional test, color Doppler, MRIs at 6 and 12 months. And at the unprogrammed check by the neurologist in charge in the case of suspected relapse, adverse events, and intercurrent clinical events to be evaluated. This study was constructed according to the criteria of independent clinical research. Funding is from Regione Emilia-Romagna and allocated €2,700,000. The steering committee is really an interdisciplinary steering committee with majority of neurologists, representation by interventional radiologist and vascular surgeon, expert in statistics, and are delegated by the promoter of the study, which is my hospital. Thank you very much for your attention.
Any questions to this very promising trial?
Yes, it's a very tough trial because the primary endpoints are really difficult, but probably convincing.
So let's move to this awards.
Okay, now we move to the awards. Please give me bots. Okay, now, yes. Now there are the awards for the young investigator in the second edition of the International Society for Neurovascular Disease. Female are really prevalent this year. The awards for young investigator oral will be done to Stefania Marcotti for a lumped model for the study of cerebrospinal veins flow.
It's first one.
Okay.
First.
Yeah, no, it's two prizes. Okay. It is the first. Okay, Stefania.
Thank you.
Congratulations.
Thank you.
You may say. Okay, thank you very much. And the second is given to Marcella Lagana for evaluation of cerebrospinal fluid flow in multiple sclerosis patients. Congratulations, Marcella. Fate una foto anche insieme. Okay. And now we move to the awards of a poster session. The first award is Anna Maria Malagoni, Evaluation of Muscle Metabolism in Multiple Sclerosis, a near-infrared spectroscopy-based evaluation. Congratulations, Anna.
Congratulations.
At last but not least is Laura Facchini for a model of filtration and transports across the brain-blood barrier.